Good afternoon, and welcome to today's webinar, Understanding Torch Infections from both a clinical and personal perspective. I'm Dominic Rizzo, and I'll be your moderator for today's event. Today's webinar is part of the Thought Leadership Series, supported by a generous grant from Siemens Healthineers. AACC has partnered with Siemens Healthineers to bring you this webinar series, which will continue throughout 2019. As a global leader in medical technology, Siemens Healthineers is a trusted partner focused on digitalizing healthcare with innovative data-driven IT and AI solutions to derive insights and improve operations. This program is accredited for Accent Continuing Education credit. Please note that this webinar has been previously recorded and can be stopped or paused at any time. Again, thank you for joining us in today's Siemens Healthineers Thought Leadership webinar, Understanding Torch Infections from both a clinical and personal perspective. Our first speaker today, providing the clinical perspective on torch infections, is Dr. Pablo J. Sanchez. Dr. Sanchez is a principal investigator in the Center for Perinatal Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University College of Medicine. Dr. Sanchez is a board-certified neonatologist, a pediatric infectious diseases specialist, and the Director of Clinical and Translational Research in Neonatology at Nationwide Children's Hospital. Dr. Sanchez, you may now begin your presentation.
Thank you. It is a pleasure to discuss congenital infections with you, and certainly I will be discussing the clinical perspective. To start off with, my disclosure statements, I have grant support from Merck and MedImmune, as well as have been on the advisory board panels for AstraZeneca and Sanofi Pasteur. The objectives of our webinar today is to really know the organisms that can cause congenital and perinatal infections, and to know how best to diagnose these infections in neonates, and to know the optimal strategy for screening, diagnosis, and for treatment of congenital CMV infection in particular. So first of all, definitions. I think we need to know when we use these terms, what do they actually mean? And congenital infection is really an in utero transplacental infection, those infections that are acquired by the fetus through the placenta from a mother who's infected, versus in utero, which can be from an ascending route usually after rupture of membranes. Perinatal infections are those that are acquired by the newborn around the time of delivery, usually intrapartum, and it's important to know the timing of when transmission of these various agents can occur, because whether it's through prenatally, transplacentally, or whether it's a natal or intrapartum, or are these infections, can they be acquired postnatally? Because knowing the timing of when the fetus or the newborn can become infected can lead to successful preventive strategies. So with that, let's discuss what are we talking about. In general, this is pictures of babies with these called congenital infections. Many of them may be small for gestational age. They may have intrauterine growth restriction, oftentimes jaundice with direct hyperbilirubinemia. Hepatosplenomegaly is quite common in those babies who manifest signs of a congenital infection. Low platelets, they can have manifestations with petechiae and purpura. And as you can see in the bottom two pictures, you can see these petechiae and palpable purpuric lesions, which reflect extramedullary hematopoiesis. It was originally described with congenital rubella, but because of toddler immunization with rubella vaccine, it is now more commonly seen with congenital cytomegalovirus infection. Microcephaly, cerebral calcifications, chorioretinitis. So in these babies, so-called symptomatic babies who manifest signs of having been infected in utero and as a fetus, these is what we typically see that make us think of which one this could be. However, the majority of infected babies are asymptomatic. They look completely normal at birth. And that's why we need to think about screening studies in mothers to see if we can detect this earlier before these babies develop the sequelae that have been associated with several of these congenital infections. So because of that, because of the fact that so many of these babies look similar and many of them may be asymptomatic, Andy Nomius, who's an immunologist and a pediatric infectious disease specialist at Emory, back in 1974, he was the one who first coined the acronym TORCH, with T being toxoplasma, O other, R for rubella, C for cytomegalovirus, and H for herpes simplex. And so this was a way of trying to alert people and clinical providers as to what kind of things they should be looking for. So why TORCH? Why this acronym? Because oftentimes they're clinically indistinguishable since they share similar clinical features that I showed you earlier. The fact is that many of them are clinically inapparent, and many of them do go undiagnosed if we don't do the appropriate screening of mothers. But still, even among asymptomatic, normal-appearing babies, particularly with CMV, some of these babies may later develop sequelae, such as sensory neural hearing loss, that from a congenital CMV infection that was not detected. Similarly with congenital toxoplasmosis, and certainly with syphilis. And the fact is that many of these congenital infections are preventive, are amenable to preventive and therapeutic measures. So Dr. Nomias recommended that when we consider these so-called TORCH infections, that at that time that a TORCH titer or panel be performed. And what exactly is this TORCH panel? Well, remember, this was many years ago, where it was all serologic assays for antibodies to each organism. And initially, they were IgG, and later on, as specific IgM assays became developed, they were incorporated into the panel. So they were for toxoplasma IgG and later IgM, rubella IgG, IgM, CMV IgG, IgM, and even herpes IgG and IgM, and then cord or serum VGRL or RPR for syphilis testing. So this is what was first told that physicians should and healthcare providers should get these titers on the mother and on the baby and then compare. And the reasoning behind it was that passively transferred maternal antigen-specific IgG antibody present in the newborn would be lost during the first few months of age in uninfected infants, and therefore if they were positive but then they became negative in the first few months of age, then that baby was felt not to be infected. And the fact that if the IgG antibodies then persisted to that agent for months thereafter, then that baby was considered to be infected. And as we know, IgM antibody is a large antibody, does not cross the placenta, neither does IgA or IgE. And so the presence of it in the newborn was indicative of fetal infection. Well, all of these three classifications have undergone a lot of reanalysis, and they pretty much, the first two definitely, the problem is, as I'll mention, is that that IgG from the mother to the baby can persist as long as 18 months. And IgM can have false positive results. So it does not always indicate fetal infection. So with that, let's just spend a little bit of time talking about IgG antibodies. Because IgG antibodies that from the mother crosses the placenta is an active transport process through the placenta, and transfer actually begins quite early, around 17 weeks, and increases as gestation advances. And at 28 to 32 weeks, IgG levels, overall IgG levels in the fetus are about 50% of maternal levels. By 33 weeks, the maternal and fetal IgG levels are the same, but by term, the fetal IgG concentration is actually higher than that of the mother. And what we also have come to realize, a lot from the HIV experience, was that maternal IgG in babies can persist up to 18 months. So it's only up to greater than 18 months of age, around 24 months of age, that we can reliably say that an IgG to a specific agent in the child is actually indicative that that child is infected with it. And a a syphilis IgG in a baby up to 18 months, a CMV IgG in the baby up to 18 months, a toxoplasma IgG in the baby up to 18 months. We just don't know if it's mother or if it was the infant who got infected and still has persistence. We have to wait sometimes as late as 24 months to reliably say that that is not maternal and then this is the infant. So these IgG assays are very problematic in the first 18 months of age. So the idea of these torch panels was evaluated back in 1983 by Leland. And she studied 381 infants less than 6 months and performed the recommended toxoplasma, rubella, CMV, herpes, IgG antibodies. And only 9% had appropriate follow-up studies. Remember, the plan was that these IgG studies should be repeated at 3, 6, 9 months, whatever, and that if they persisted for much longer than 6 months, that baby was infected erroneously. But very few had follow-up titers done. And 3 infants were diagnosed with CMV and toxoplasmosis by other methods. And actually, in these 381 infants, there was no so-called torch infection that was diagnosed only by serologic assays. And her conclusion, which I support, is that the torch designation leads to inappropriate diagnostic tests, including torch panel, which has very poor diagnostic return. And we all clinicians who have dealt with these with circumstances in neonates in which the mother and the baby gets these panel of studies, we generally don't know what to do with them if they're positive because it could all be maternal. And actually what's helpful is if it's negative, because if it were to be negative, and IgG is negative in the baby, then actually that baby was never exposed to that infection because the mother's never had it to develop an IgG. So rather than looking for positives, sometimes the negative is actually more helpful. Again, going against this torch panel. However, people have tried to make this acronym even more expansive. And Plotkin, who's a very famous pediatric infectious disease specialist in Philadelphia, in 1986 thought we should go to crotches because Coxsackie, we know, can also cause congenital infection, and wanted to include syphilis as well. And Plotkin again thought maybe 1989, that's when we were seeing the HIV infection at that time called acquired immunodeficiency syndrome. Also, SCRATCH was a new acronym. And then in Sherman in 1989 decided CHARTS would be a better one because there they added the AIDS viruses, which as you know, we now call human immunodeficiency virus. And then in Nave in 1982 said slave torch, and people then really became slaves to this acronym where they wanted to do all of this testing. And really what we have to keep remembering is that the diagnostic return of a panel of tests is really very, very poor. And certainly there is an ongoing need for continuous search for candidates in the other category. This was stated by Namias in 1974. And it's true, we really need, there are new candidates always occurring. And I have this slide here of all the potential etiologic agents that could cause congenital and perinatal infections. And there's others. And more recently, as is highlighted on this slide, the Zika virus was a cause that had not been considered previously. Congenital Zika syndrome, we are, I don't want to say we're lucky, but as a neonatal infectious disease specialist, it was exciting in a very negative way because certainly it was a tragic occurrence. But we witnessed a designation of a new congenital infection with Zika, and these babies were severely microcephalic as shown here, and with these, on the scalp there was overlying skin that was almost shrunk because it was almost like the brain and the head had been growing, and then the fetus and the fetal brain got infected with the Zika virus that led then to the microcephaly and the brain not growing and this Rouget type appearance. And these babies have lots of problems. They're at risk for seizures, microcephalic, as I mentioned, coordination difficulties. They have ultimately short stature, and they are plagued with hyperactivity. and certainly a lot of neurodevelopmental delay, and that opistotonic type posturing as well, with contractures is also seen. And very commonly also a very typical chorioretinitis where ophthalmologic evaluation was critical. And this was well described in the New England Journal report that Zika is definitely a cause of microcephaly and other serious brain defects. And this article reviews the evidence for causality of the Zika virus. So my short of it is that we need to start forgetting about the TORCH acronym if it's going to lead to TORCH panels. And what we need to do is start thinking more selectively, because we need to think about a selective use of which antibody determination is helpful. There's been this use of total IgMs, and again, remember, IgM is produced by the fetus or by the fetus, and it's a large molecule that does not cross the placenta. So if you detect IgM in the newborn blood, it does not reflect IgM from the mother, but it's that the baby's been producing his own IgM antibodies. However, most, if not all of these tests have false positive IgMs. The sensitivity has been, in all IgM assays, is suboptimal, and there is definitely all of them, even among the better IgM specific tests, there's false positives. And similarly, total IgM is not helpful. There are babies born with florid congenital infection in which the total IgM is completely normal, and there are babies who are completely normal, whose IgM is sky high, and yet they're completely normal and not infected. So total IgM is something that should be taken out of the laboratory. So we should know which antibodies to test selectively. We should know which ones we would prefer to use culture and or PCR. Polymerase chain reaction has revolutionized the diagnosis of many infections, certainly HIV, but it certainly has revolutionized the diagnosis of congenital infections in babies. And we would prefer a culture or a PCR in the baby than relying on antibody titers that, as I mentioned, may reflect maternal antibody or may have false positive results. And then I think very importantly is that we need to know the appropriate person to screen, because do we do the mother, do we do the infant, or we do both? And I think that's an important concept, because we have to recognize that whatever this fetus, this newborn has, if he has a congenital infection, we have to recognize that there's only one person who transmitted this infection, and that's the mother. I mean, that's one of the reasons I like neonatal infectious disease. It's kind of simple-minded. And so if we know the only exposure was the mother, we should first evaluate her and then see what she has, what she doesn't have, and that way will lead us to what specific tests should be done on this baby. And always, don't forget the placenta. We, as a neonatologist, if we suspect any congenital perinatal infection in the baby, we really should evaluate the placenta, because we and others have shown that it improves the diagnosis of congenital syphilis. We have seen some babies, some placentas of babies with herpes that have the pathologic diagnosis of possible herpes infection, and certainly with CMV can also have some abnormalities with parvovirus and toxoplasma as well. So all of these congenital infections, the placenta may help with that diagnosis, and it should be sent to pathology and with careful discussion with the pathologist as to which agents you might be looking for. So women are screened routinely for certain infections. That is, every mother in the United States should have at least one syphilis test done at the first prenatal visit. And I'll discuss a little bit more about the syphilis testing, but HIV is also done, rubella IgG is done, and hepatitis B surface antigen. Now, we don't do routine herpes testing. We don't do in the United States routine toxoplasma testing, and I know that the next speaker will speak more on CMV, IgG, and screening, but that has not been a recommendation from the American College of Obstetrics and Gynecology. And hepatitis C IgG has also been only done for risk factor based, although a recent recommendation that is up for review is that we should have universal hepatitis C IgG testing in mothers because the transmission can be about 5%, and we're now is a treatable infection. So these are what we oftentimes consider in terms of maternal screening, some done routinely and some done as needed. So let's talk a little bit about the syphilis testing, because I think that is something that we are seeing a lot of. From 2008 to 2017, you'll see the green bars are the cases of congenital syphilis that have been reported to the Centers for Disease Control, and the line is the cases of primary and secondary syphilis in women in the United States. And you can see from 2012, there's been a significant increase in both cases of primary and secondary syphilis, which is the most infectious stages of syphilis in women, and also you've seen a significant rise in congenital syphilis cases, whereas congenital syphilis increased 44% from 2016 and 153% from 2013, with a parallel increase in women, respectively. And in 2017, 922 cases were reported to the Centers for Disease Control in the United States, and there were 64 stillbirths and 13 infant deaths. It is a major cause of neonatal mortality worldwide. So it's on the rise, and so we need to test these mothers because it is a preventable infection of the fetus. We can identify these women, and we can treat with benzathine penicillin infected women, thereby preventing vertical transmission. So babies who are born with congenital syphilis, you'll see non-immune high drops. They'll have hepatosplenomegaly there. They'll have the rhinitis, the rash that you can see there, and also it can affect the bones as well. And on the lower left-hand column, if you looked at fluid from these babies, the nasal fluids or from the lesions, on the dark field microscopy, you'll see the spirochetes, the motile spirochetes. However, again, the majority of babies infected with syphilis because of maternal syphilis, the majority of them are asymptomatic. And so because of that, we need to ensure adequate prenatal care so that these women are tested. At the first prenatal visit and in areas of high risk, they should be repeated at 28 to 32 weeks and at delivery. Traditionally, we have tested women with RPR, rapid plasma reagent, and if that's reactive, then we do a specific treponemal test, T-pallidum, and the recommended treponemal test is the treponema pallidum particle agglutination. However, many labs have moved to what we call a reverse sequence screening for syphilis. Remember that to do an RPR and a TPPA, you have to do individual samples, and it's very time-consuming. Whereas if you screen with these panels for treponema pallidum IgG, syphilis IgG, you can do a whole bunch of women and adults and individuals at once. And so they have moved towards this reverse screening algorithm, whereby they do the syphilis IgG first, and if it's positive, then they do the RPR. If it's positive, then it's considered to be syphilis. If the RPR is negative, then they recommend doing the time-honored treponemal test, which is the TPPA. If that's positive, this woman has either had syphilis in the past or presently is having syphilis because the treponemal assays are actually become reactive before the non-treponemal. But if it's negative, we consider that syphilis is unlikely, and that may very well have been a false positive. We here at the Ohio State Wexner Medical Center, in situations where the T-pallidum IgG is positive, the RPR is negative, and the TPPA is negative, that occurs in about 70% of the time. We see a lot of what we consider to be false positive T-pallidum syphilis IgG assays, which is problematic. So again, we need to know how best to test these mothers and babies. So we also recommend HIV antibody testing. Again, this baby cannot be infected with HIV unless the mother has been infected. And we do it at the first prenatal visit, and the recommendation has generally been to repeat it at the beginning of the third trimester. And then if it's positive, we get a viral load. and then we institute antiretroviral therapy. And with that, with all of these interventions, we've been able to decrease vertical transmission to less than 1%. So it's really been a success story. Rubella IgG is done routinely, but what's more important, rather than rubella IgG being positive, is rubella IgG being negative. Because if she's negative, that woman should be vaccinated postpartum in order to prevent a congenital rubella with a subsequent pregnancy. Hepatitis B surface antigen is routinely done at the first prenatal visit, and if it's positive, currently people, obstetricians are doing a viral load, that if it's very elevated, anti-hepatitis B treatment with tenofovir or lamivudine is being recommended to prevent transmission, although the majority occurs at the time of delivery. And so some of the other assays have not been routinely done. Herpes IgG is not routinely done unless the mother gives a history of possibly having herpes in the past. And I mentioned the hepatitis C. CMV will be discussed more. I just wanted to mention a little bit about Toxoplasma IgG. So again, if you suspect, if this mother has a history of cat exposure with changing litter boxes without gloves and with not good hygiene, but actually most of Toxoplasma transmission occurs from eating undercooked meats and undercooked ham, and also just from eating improperly washed fruits and vegetables, because they can contain the Toxoplasma parasite from cats that have excreted the parasite. So if there's any suggestion, or if the baby has signs like I showed you in the beginning with hepatosplenomegaly, any concern for toxoplasma in the baby, the best thing to do is to do a Toxoplasma IgG on the mother at the time of delivery. If it's negative, she's never had it. So we don't need to do a lot of things to the baby. But if she's positive, then the question is, when did she get it? How long has she had it? And if she had it during the pregnancy, did the transmission occur to the fetus? And if the mother is positive and you think that there could be toxoplasma in the baby, we can detect the Toxoplasma gondii DNA in the amniotic fluid, in fetal blood, and in neonatal blood and CSF. So PCR can be done, and we can also examine the placenta as well. Again, the examination of the placenta is also helpful, but we're oftentimes left with serology in these babies and in the mother and the baby. And in this case, this is where serology is helpful. And the reference lab for Toxoplasma serology is the Remington's lab in Palo Alto, California. And on the mother, we get a toxo IgG, which we know is positive because that's what prompted further testing. We can do an IgM ELISA, and what the Palo Alto lab does is an ACHS differential agglutination test that lets us know it's IgG antibody directed against specific antigens of the organism, and lets us know if the infection could have been acquired in the distant past before the conception, or was it acquired during the pregnancy? Because for women who are immunocompetent, who do not have any problems with their immunity, it is primary infection or reinfection during the pregnancy that leads to congenital infection. If a woman has immune system is normal and she got infected before conception, then the baby it's not a concern for infection of the fetus. And in the baby, then they do the IgM ESAGA is a type of an ELISA, and they also do IgA ELISA and IgE ELISA as well. So those are helpful in trying to determine whether this baby could be infected or not. And we do serology for toxoplasmosis more commonly than PCR for screening. But again, we need to know what actually might be better to diagnose these infections. And for CMV, urine is really still the diagnostic place rather than antibodies. CMV IgM not only has a very low sensitivity of only 60 to 70% of babies with congenital CMV will have a CMV IgM positive, but also CMV IgM can be falsely positive both in pregnant women as well as in babies. As many as 5 to 10% of pregnant women and babies with CMV-IgM will be positive, but they do not have ongoing CMV infection. And so we prefer PCR than culture, but we can certainly culture, a rapid culture with CMV is also very possible. Saliva has been an excellent place for screening, as I'll mention later, but the diagnosis remains based on urine. Viral isolation, we can also do enteroviruses and herpes, but really PCR has revolutionized the diagnosis of these infections. And you can see different organisms there that are very amenable for diagnosis for PCR. And then antibody assays, as I mentioned, syphilis and rubella. Rubella does have there's been a recent PCR for rubella, but for years we had to rely on IgM testing. And so rather than doing these panels where they're giving us IgG assays that are oftentimes not very helpful at all, we then should think about what could this baby have, and then from there know how best to diagnose that specific infection. So CMV makes a baby who presents with microcephaly, periventricular calcifications, thrombocytopenia, splenomegaly, and very importantly, sensory and oral hearing loss. Those who refer on the newborn hearing screen makes us want to think about CMV and should lead us then to do a urine CMV PCR test, not all of these antibody assays that are not going to be helpful ultimately. We have an excellent method of detecting the viral DNA. Herpes, similarly, we have PCR as well as culture detection, and in babies who present with rash, like here, these vesicles, then they really are the ones that we think about doing the PCR detection for herpes DNA. Babies who present with osteochondritis, periostitis, rash, rhinitis, like I showed us, should make us think of syphilis. But if we test the mother at delivery and her syphilis test is negative at the time of delivery, we don't need to do more tests on this baby. That baby has never been exposed. And we should also think about lymphocytic, I'm sorry, there's a noise. So we should also think about LCMV, or lymphocytic choriomeningitic virus. We should think about this virus as an arenavirus that infects individuals and pregnant women through rodents. And we should think about this virus when we think a baby may have congenital CMV infection with periventricular calcifications, chororetinitis, hepatosplenomegaly, but the CMV testing is negative. Unfortunately, all we have are serologic assays for its diagnosis. Parvovirus, in utero fetal hydrops, and anemia. And varicella would be in babies who present, if the mother has had chickenpox in the second trimester, they can present with these scarred lesions as well, which is different than a baby who gets varicella after birth. Rubella, we should think about in babies who are small for gestational age, who have cataracts, who may have cardiac defects such as patent ductus arteriosus and blueberry muffin spots. Fortunately, toddler immunization and postpartum immunization with rubella has eliminated congenital rubella in the United States, which is our hope, our future hope with cytomegalovirus. And in terms of hydrocephalus, generalized intracranial calcifications and chororetinitis should make us think of toxoplasmosis. Microcephaly with parents, mother or father who have traveled to an endemic area, should make us think of Zika virus. So in conclusion with this first part of the presentation on torch panels, I think there's no question that these congenital infections are important to diagnose because some of them are treatable, including cytomegalovirus now. All have important prognostic implications. And if we don't diagnose them, we have missed the opportunity to prevent later sequelae and to improve the neurodevelopmental outcomes of these babies. And the torch panel is not useful, but we should really be selective screening of the mother to think of the routine prenatal tests that are being done, and also looking at the baby to see what the symptoms and signs that are present in this baby could be, what agent could be the cause of it, and then do selective testing, whether that's be antibody testing, culture, PCR testing as well. So I want to then switch over to congenital CMV infection, which really is a huge hot topic right now in the United States and on a global basis. CMV is a huge public health problem worldwide. It is a human cytomegalovirus. We only have humans to blame for infection. This CMV is a human virus. It only infects humans. We cannot blame the mosquito. We cannot blame the cat. We can't blame our dog. We can't blame the rodent for causing infection in us. We get infected with throughout our lifetime because we are exposed and we get exposed to a lot of body fluids. So it's a huge public health problem because it infects about 1 out of every 200 babies born in the United States. It is the most common congenital viral infection. And this translates to about 40,000 infants born infected each year in the United States, and over 8,000 of them may have sequelae or fatal outcome, with the most prominent being hearing loss. But CMV, when it infects the fetus early in gestation, can cause the neurons, the brain cells, not to migrate well and cause the malformations of the brain. It can really destroy the brain and cause these calcifications that you see in the panel with the CT scan. The white spots reflect calcifications, and the black reflects all areas of cerebrospinal fluid that's taking up really destroyed brain. So it's not surprising that this child, when she was 5, 6 years of age, had cerebral palsy, spastic quadriplegia. She needed a G-tube for feeding. She was completely deaf, and she also had cortical blindness. However, the majority of babies look completely normal. 90% of these babies born with CMV are completely well. They're in normal newborn nursery, and we don't even know. They're so-called asymptomatic. Only about 10 to 15% manifest the signs of the infection. So this infection, CMV, can be acquired by a woman for the first time during the pregnancy, and 40% of the time the fetus becomes infected. The placenta does form a barrier. 60% of the time the mother may have a primary CMV infection for the first time during the pregnancy, but the fetus only gets infected 40% of the time. CMV is a chronic infection. We are infected with CMV for the rest of our lives. It never leaves our bodies. It's within our white cells. And periodically it becomes active in all our body fluids, and we don't feel any different. We feel completely the same. But during the time that it's active, it's present in saliva, it's present in urine, it's present in breast milk, it's present in semen. Any of our body fluids can contain this virus. And so as we share body fluids with each other, we drink from a lot of people's cups, we sample their foods through their forks and spoons. Some mothers may even put pacifiers from their babies into their mouths. Children in daycare, everything goes in their mouths. So we get exposed to this virus a lot, and that's how we all get infected. So a woman who's had CMV before can become active during the pregnancy and can lead to fetal infection as well, although generally it's milder than primary infection. But what we also know is that a woman who's had CMV before the pregnancy and she is CMV IgG positive can get reinfected with a different strain, and then that reinfection can lead to severe congenital infection. So all of these precautions need to be taken by pregnant women, whether she's ever had CMV or not. We need to take precautions that Lisa will speak to you about later in order to prevent congenital infection. And so the biggest issue with CMV currently is the fact that it's the most common non-genetic cause of sensory neural hearing loss in infancy. And among babies who look completely well at birth, they're in the normal newborn nursery with their mothers, breastfeeding, doing great, they're going to go home. but then they refer on the newborn hearing screen, on the newborn hearing test, and about 7% of them will have sensory and oral hearing loss detected at the initial exam. And what's very important is that as many as 18% of them will pass their newborn hearing test but develop hearing loss later, usually in the first 5 years of age, but more commonly somewhere in the 2 to 3 years. And it can even be it can occur even beyond 5 years. I tell the parents of my congenital CMV babies that it can be through adolescence and maybe even adulthood. We just haven't been testing babies and screening babies for congenital CMV. And so maybe even adulthood, we just don't know. But certainly through adolescence. I've recently had 2 children who at 6 years of age developed unilateral profound sensory and oral hearing loss, and they're going to be getting cochlear implant in that year. And previously, they did have congenital CMV infection, and previously their hearing had been completely normal. So it's something that we need to be aware of. Among babies who present with signs of congenital infection, about 50% of them will have hearing loss, but 30% of the 50%, they pass their newborn hearing test, but then they have delayed onset hearing loss. That's why we recommend in babies where we know have congenital CMV, even if they pass the newborn hearing screen, we retest them at 3 months, we retest their hearing at 6 to 7 months, at 12 months, every 6 months through 4 years of age, and then yearly through childhood. And certainly at any time that the mother suspects that this child may not be hearing. But this is the reason why we really want to institute universal testing of all newborns for CMV. It's really, it's being presented to the newborn hearing program in the United States. We have not yet heard back from them, but certainly that's our goal. And the reason being that it's easy to diagnose congenital CMV. We can detect this virus in culture or better yet, by PCR. We can do saliva screening because CMV is a salivary gland virus, is present in our salivas when it's active. And in these babies, they shed the virus in their saliva. We can screen it. And if that's positive, then we need to confirm it with urine because there are positive saliva CMV PCR where the urine is negative. This baby could have acquired the infection from breastfeeding or acquired the virus from the breast milk and not be infected. And because breast milk commonly contains CMV, and also this baby could have acquired the CMV as he was being born, because about 10 to 15% of women who are CMV IgG positive at the time of delivery, they have CMV in their vaginal cervical secretions, and maybe what we're detecting in the mouth is just some exposure rather than infection. And so any saliva screen has to be confirmed with a urine culture or PCR. As I mentioned before, CMV IgM is a horrible test. If you work in a lab, if I worked in a lab and I got an order for CMV IgM, I would call the provider and tell them this is not how we diagnose CMV in a neonate. The thing with CMV and diagnosing congenital CMV is that we have to diagnose it in the first 3 weeks of age, because after 3 weeks, we don't know if the baby acquired it as he was born or through breast milk or through other children at home, from other people at home who may be shedding CMV, or even in a daycare. And so after 3 weeks of age, it becomes very, very difficult to diagnose it. And so that's why we're really wanting babies screened for CMV at birth, particularly if they refer on the newborn hearing screen. And we do it whether they refer on one ear or both ears. It doesn't matter. CMV can give you unilateral hearing loss, and babies who refer even in 1 ear should have a CMV test performed. And the preferred test is the urine PCR. So any baby who has any manifestations that, like I showed you earlier, that could be CMV, we would do a urine CMV PCR. We also feel very strongly that babies born to mothers who are HIV positive should also be tested for CMV, urine PCR, because as many as 3 to 9% of these babies can be infected congenitally. because women who are with HIV, their immune systems is not normal, and they can reactivate CMV commonly during the pregnancy. And then, as I mentioned, those who refer on the newborn hearing screen. And we started screening babies for testing babies. Really, we should be talking about testing, because referral on the newborn hearing test, we should test babies for CMV. And we showed in Dallas, where I was before, that as many as 6 to 8% of these babies who refer on the newborn hearing test will have congenital CMV infection. So I just want to mention, and I know Lisa will be speaking, that now there's been laws passed in Utah, Connecticut, Iowa, as well as in New York, where they mandate that if the baby refers on the newborn hearing test, that the baby be tested for CMV. Saliva is an excellent screen. That's an easy one to do. It can be done, but if it's positive, then do the urine. If you have the chance to get the urine, it eliminates the two-step diagnosis. Now, so this has been called more targeted approach. And I just want to mention that here in Columbus, we're actually testing all admissions to the neonatal ICU for CMV. We're doing saliva screening, and if positive, confirming it on the urine. And the reason being that many of these babies do not get tested for CMV, do not have a newborn hearing test done until after 3 weeks of age, in which case we don't know if we test them after 3 weeks, whether it was a congenital infection or acquired intrapartum or through breast milk acquisition. So we're doing every single newborn. We started this about a year ago. And the reason we want to identify these babies in the first month of age is because we have treatment. Babies who have symptomatic congenital CMV, it's been shown that by treatment we can improve hearing outcomes. And in this first study that was published in Journal of Pediatrics, babies with a central nervous system involvement secondary to CMV, they were randomized to get cyclovir IV for 6 weeks or no treatment. And what was shown in this study was that looking at the babies who got the ganciclovir for 6 weeks intravenously compared to no therapy, they had improved hearing or remained normal in 85% of the babies at 6 months versus only 56% in the ones who did not get treated. And very importantly, at 6 months, none of them had worse hearing versus 44% in the no therapy group. So you see how hearing loss secondary to CMV can progress. And at a year of age, 52% had improved hearing or remained normal versus 25% in the no therapy group. And again, there was less worse hearing in the treated group. So it's really important to try to protect hearing in this first year or two when these babies are developing speech, when all the brain connections and wiring are occurring, so that we can optimize their hearing outcomes. So if 6 weeks was good, maybe 6 months is better. So in this follow-up study, all babies who had any signs of congenital CMV infection, not just those in the central nervous system, all of them received 6 weeks of oral valganciclovir treatment. And then they were randomized to continue oral treatment for up to 6 months versus a placebo. And what was shown at 6 months, that there was no difference in the group who got treated from. So all of these babies were symptomatic. They received 6 weeks of treatment, and then randomized to continuing valganciclovir for 6 months versus placebo. At 6 months, the hearing outcomes were the same whether they received 6 weeks or 6 months. But at 24 months, their hearing outcomes was significantly improved. And when looking from birth to 12 months, also it was significantly improved. And so, so our recommendation now is to treat these babies for 6 months of therapy, of antiviral therapy. When we also did some neurodevelopmental assessments at 6 weeks versus a 6-month group, the ones who got treated for 6 weeks had improved language and receptive communication skills significantly better, not surprising because they had improved hearing outcomes. Unfortunately, the motor, fine motor, and gross motors were not statistically significant between the two groups, But when you look at the actual scores, they were much better in the 6 months. So we do feel that there's likely improvement in neurodevelopmental outcomes as well as improved hearing. But the evidence for neurodevelopmental outcomes is less strong than for hearing. So in conclusion, congenital CMV, it is really time to act. We do need to start at least targeted screening and as we move towards universal screening. And so I'd like to conclude that research saves babies. A lot of these studies with CMV have been, I want to thank the parents who allowed us to enroll these babies. And this is my contact information. I'm glad to have, if you can email me, call me. I'm glad to help in any time that it comes up. Thank you. Thanks for listening, and thanks for participating in this podcast.
Thank you, Dr. Sanchez, for sharing that presentation with us. Our second speaker today, providing the more personal perspective on torch infections, is Mrs. Lisa Saunders. Lisa Saunders is the mother of Elizabeth Saunders, who was born severely disabled by congenital cytomegalovirus, or CMV, in 1989. Just prior to her pregnancy with Elizabeth, Lisa had a miscarriage but was not tested for CMV or other prenatal infections. Until Elizabeth's birth, Lisa was unaware of CMV, and although she was a licensed in-home child care provider, a church nursery volunteer, and the mother of a toddler, all activities that put her at high risk for CMV, she was not educated about the disease and how to reduce her chances of contracting it. In 2015, she was instrumental in helping Connecticut become the second state in the U.S. to enact a law requiring the testing of newborns for CMV if they fail their hearing screen. A graduate of Cornell University, Lisa is an award-winning writer, author of several books, some with a CMV prevention message, and is the leader of the Child Care Providers Education Committee with the National CMV Foundation. Mrs. Saunders, you may now begin your presentation.
Hi, thank you very much. All right, I need to be able to switch my slides. Here we go. Okay, again, I was unaware of CMV risks and prevention. That's me pregnant with Elizabeth. When I was pregnant with Elizabeth in 1989, I was at a high risk for CMV because I was the mother of a toddler, a licensed home daycare provider, and volunteered in our church nursery. 3 months prior to my pregnancy with Elizabeth, I had a miscarriage. I didn't know about CMV. Toddlers in group care spread infections such as CMV. They put each other's toys in their mouths. They mouth each other's cups, utensils, and toothbrushes. They need adults to wipe their noses, feed them, and change their diapers. Quote, children enrolled in child care facilities are more likely to acquire CMV than are children cared for at home. This is according to the American Academy of Pediatrics. Child care and CMV. 8 to 20% of child care providers contract CMV every year as compared to 1 to 4% of women who have never had CMV in the general population. On average, 30 to 40% of preschoolers in daycare excrete CMV in their saliva and or urine. And up to 70% of children ages 1 to 3 years in group care settings excrete the virus. Parents of children in daycare centers are at increased risk for contracting CMV. According to Dr. Jason Brophy, a pediatric infectious disease specialist, quote, almost all the babies that I see who have congenital CMV, there is an older toddler at home who is in daycare, end quote. Child care providers are largely unaware of CMV, and many acknowledge using diaper wipes to clean. Diaper wipes do not effectively remove CMV from hands. Again, I suffered a miscarriage just prior to my pregnancy with Elizabeth. That was on Christmas Eve, 1988. And although I was at high risk for CMV, I didn't know about the virus or be tested for it to see if CMV could have been the cause of the miscarriage. If it was shown to be a possible cause, I would have waited to get pregnant again. I got pregnant as quickly as I could after the miscarriage, 3 months later. A sonogram at 4 months showed the baby was smaller than expected. No further testing was suggested or done. My daughter Elizabeth was born severely disabled by congenital CMV in 1989, and that's her, the first time I held her. Her head was small and deformed. She had microcephaly. I was told she would never roll over or sit up. She never did. I was told she would never speak. She never did. Her temporary symptoms at birth were the purple skin splotches, lung problems, small size, seizures. Her permanent symptoms and disabilities were hearing loss, vision loss, mental disability, small head, lack of coordination, seizures, and death. And Elizabeth is seen here in 2005 at the age of 15 with her big sister on our last family vacation together before she passed. And she died in 2006 at the age of 16 during a seizure. And that's her stone. She is forever sweet 16. After her death, I had more time to think about what was going on in the world as far as CMV awareness. I had a tormenting dream about young parents wondering why I didn't do more to warn them about CMV. So I began researching CMV awareness and prevention. A 2006 survey, Knowledge and Awareness of Congenital Cytomegalovirus Among Women, concluded that only 22% had heard of it, and most of those could not correctly identify modes of CMV transmission or prevention. And the only way I can find peace now is to help future babies escape my daughter's suffering. Moms want to know how to protect their babies. That just happens to be family cows from years ago. But anyway, a mother wants to know. In 2014 and 2015, I helped encourage Connecticut to pass a law requiring targeted CMV testing. It passed in 2015, but prevention education didn't pass because of funding. And that's us at the ceremonial signing. As of 2016 in Connecticut, newborns are tested for CMV if they fail their hearing screen. And according to Dr. Brenda K. Balch, Connecticut's American Academy of Pediatrics Early Hearing Detection and Intervention Chapter Champion, the CMV, quote, testing protocol allows for a more timely diagnosis of the etiology of the infant's hearing loss and is less expensive than imaging and genetic testing, end quote. A CMV testing law also increases healthcare workers' and parents' awareness of CMV research and possible intervention strategies for congenital CMV. This is what I would have done differently had I known about CMV. That's me speaking at the CDC. I would have gotten tested to see if I had any antibodies to CMV prior to getting pregnant. I would have gotten tested after suffering a miscarriage to see if CMV could have been the cause, so I could wait before getting pregnant again. Knowing how difficult it is to prevent contracting CMV in a group child care setting, I would have not professionally cared for toddlers, nor would I have volunteered in our church nursery. And more importantly, and most importantly probably, I would not have shared food and cups with my toddler, nor let her kiss me on the lips. Child caregivers should be counseled about CMV. Unfortunately, most are not. Quote, in view of the risk of CMV infection in child care staff and the potential consequences of gestational CMV infection, child care staff members should be counseled about risks. This counseling may include testing for serum antibody to CMV to determine the child care provider's protection against primary CMV infection, but routine serologic testing is not recommended. And this is according to the American Academy of Pediatrics. And quote, a pregnant child care employee should be informed about CMV, assess their risk by serologic testing, or avoid, if possible, caring for children less than 2 years of age for the duration of their pregnancy, according to Stuart P. Adler, MD, of the CMV Research Foundation in his article, Prevention of Maternal Fetal Transmission of Cytomegalovirus. CMV screening and testing. According to the National CMV Foundation, every woman of childbearing age should know her CMV status. Before you plan to conceive, ask your doctor to have a blood sample drawn for CMV, IgG, and IgM antibody tests. If you have already had a CMV infection, it is recommended that you practice CMV prevention recommendations during pregnancy because it is still possible that a recurrent CMV infection or an infection from a different strain of CMV may cause mild harm to your baby. These infections are rare and generally result in less serious disability than primary infections. This is what other countries do regarding the problem of CMV in daycare. In Queensland, Australia, they suggest relocating workers who are pregnant or who expect to become pregnant to care for children aged over 2 or reduce contact with urine and saliva. And actually, a parent successfully passed a daycare worker that they should have warned her about CMV before she worked in daycare. In Germany, based on the German maternity protection law, to protect daycare workers from primary infection, their CMV serostatus must be checked at the beginning of their pregnancy. When the daycare worker is seronegative, she is excluded from professional activities with children under the age of 3 years. In 2017, I asked OSHA to educate child care workers about their occupational hazard for CMV. And I'm excited to say in 2019, they made an announcement in Quick Takes, their newsletter on workplace safety and health. They wrote, quote, "A common virus, cytomegalovirus, CMV, affects thousands of workers in child care centers and healthcare facilities. These workers are at greatest risk of exposure because the virus is often spread through saliva and other bodily fluids of young children. OSHA's new webpage on CMV explains how to minimize health risks associated with workers' exposure to this virus." This is why I believe most women have never heard of CMV. I've come up with 5 possible reasons. 1, CMV prevention education is not part of a doctor's standard of care. Number 2, doctors don't want to frighten, worry, or, quote, burden patients. According to the New York Times, quote, guidelines from ACOG, American College of Obstetrics and Gynecologists, suggest that pregnant women will find CMV prevention impractical and burdensome, especially if they are told not to kiss their toddlers on the mouth, a possible route of transmission. 3, low media coverage. In healthnewsreview.org article, "Why does CMV get so much less news coverage than Zika, despite causing far more birth defects?" the author states, quote, researchers we spoke with identified the same factors, fear and the epidemic/endemic nature of the disease, as driving the media disparity. Number 4, U.S. workers have the right to receive information and training about hazards. However, there are no federal laws governing CMV education policies for child care workers. The Department of Labor states education and training requirements vary by setting, state, and employer. Number 5, the virtual absence of a prevention message has been due in part to the low profile of congenital CMV. Infection is usually asymptomatic in both mother and infant, and when symptoms do occur, they are nonspecific, so most CMV infections go undiagnosed. How can CMV be avoided? Wash hands often with soap and water for 15 to 20 seconds, especially after wiping runny noses, changing diapers, picking up toys, etc. If soap and water are not available, use alcohol-based hand gel. Use soap and water or a disinfectant to clean hard surfaces that have been contaminated by secretions. Don't kiss young children on the lips or share food, drinks, or eating utensils with them. Pregnant women working in child care facilities should minimize direct exposure to saliva. Hugging is fine and is not a risk factor. Staff should be advised not to allow children to put fingers or hands in the other person's mouth. And that's all I have to say.
Thank you, Mrs. Saunders, for your presentation as well. And I'd also like to thank Dr. Pablo Sanchez for his presentation earlier. And thank you to all of you in the audience for listening to the Siemens Healthineers Thought Leadership webinar. To gain your accent continuing education credits and complete a short evaluation, please click on the link provided in the email. Please note that a recording of this webinar will be posted shortly on the Thought Leadership Series page on AACC's website, where there will be an archive of the webinars in this series if you want to view others that you have missed. Also, be sure to mark your calendars for the next Thought Leadership Series webinar on November 14th, 2019. For any customer-related questions, please call our customer service line at 1-800-892-1400. Thank you, and have a great rest of your day.